right, so again, we're going to finish here with a really quick discussion regarding seizures, and then we're going to move into Chapter 15 today. Okay, so that's kind of the plan for today. Finish up with seizures, and then go as far as possible into Chapter 15, and then whatever we don't finish for Chapter 15, we'll pick up with that on Monday before we talk about pediatric considerations. Okay, that's the plan for the next couple of days before the exam. All right, seizures. So we kind of briefly mentioned and kind of got a couple of things got sort of brought up about seizures on Monday. And so now we're going to sort of specifically talk about it for a little bit and just kind of make sure we're kind of on the same page regarding the pathophysiology of seizures or syndromes that cause seizures. So yeah, so seizures basically represent a syndrome. We don't necessarily say that seizures are a specific disease state. Really, in most cases, disease states cause seizures as sort of a clinical manifestation or sort of a symptom of a specific type of disease state. So seizures usually are sort of a complication or a manifestation of some other type of neurologic dysfunction alteration that's going on. But really how we define a seizure is that it's a sudden, transient alteration of brain function that's usually caused or sort of manifested by very sort of quick, explosive, disorderly discharge of the neurons in the cerebrum. And what I mean by sort of explosive and disorderly is that it's this huge increase in terms of neuronal activity for all of a sudden for some sort of reason in the brain itself, characterized by sudden, transient alteration in brain function. And when I say alteration in brain function, I mean in all kinds of different types of sort of neurologic function. So it can have motor manifestations, it can have sensory manifestations, and actually it can have more sort of involuntary autonomic manifestations as well. So that's kind of the sort of true textbook definition of a seizure. Really, again, the way that you can really think about it is brief disruption in the brain's normal electrical functioning. And again, by disruption, I mean increased functioning at times. So that this disorderly, explosive, doesn't really make sense electrical firing going on in the brain. Now, there are a lot of different types of seizures, and some of you may be more familiar with some versus others. There's absence seizures. There's what they call partial seizures. For the purposes of today, we're going to focus on more generalized tonic-clonic seizures. So, and what I mean by that is when you think of a seizure, that's sort of the stereotypical classic sort of manifestation of a seizure is that jerky, tonic-clonic, contract, relax type of movement that you think of with a seizure. That is called a generalized tonic-clonic seizure. There are other types of seizures that don't look like that don't manifest that way, but we're talking about tonic-clonic today. Okay, so in terms of that, the tonic-clonic, jerky, contract, relax movements that are associated with some types of seizures have to do with the way that the neurons, with the way that the brain is firing. And we'll talk about that more specifically in the next slide. However, even though on the previous slide I've said that most of the time seizures don't happen because of its own sort of disease state, it's happening because of some other issue going on in the brain, there is one reason, so to speak, that seizures just happen for no explained reason. And that is with the condition or the syndrome of epilepsy. Okay? So for epilepsy, there really is no true underlying cause that can be found. When doing scans of the brain, when looking at radiographical studies, CAT scans, MRIs, etc., there's nothing structurally abnormal with these people's brains. There's no issue with blood flow to the brain. There really is, for some reason, no underlying cause that can be found in people with epilepsy. No underlying correctable cause for the seizure. So therefore, the seizures that occur in someone with epilepsy, the activity is going to continue to recur because there's no problem to fix, right? There's no issue with blood flow. There's no tumor there. There's no mass there. There's nothing there sort of interrupting that electrical sort of activity of the brain. So therefore, there's nothing to fix. Therefore, seizures will continue to happen in someone with epilepsy. The only way to sort of really sort of get at the seizure activity with epilepsy is through anti-epileptic drugs, right? So just to decrease that activity going on in the brain, like Dilantin, like Cogentin, maybe some of those medications you've heard of with clinical or some of your own clinical experience and things like that. So that is one sort of side note that I will say regarding seizures, seizure activity, tonic-clonic convulsions, etc., is that most of the time they will be due to some other reason. Epilepsy is a little bit different than that. Taylor, did you have a question?
Yeah, this is kind of an embarrassing question, but a syndrome.
Yes.
Syndrome.
Yes. What do I mean by syndrome? Really what I mean by that is it's some sort of manifestation of something else that's going on. So, for example, and we'll talk about this in a couple of slides moving forward. Yeah, actually the next one. Most of the time, seizures will occur because of diseases or other processes that involve the nervous system, okay? So what I mean by seizures being a syndrome is that maybe there's some sort of cerebral lesion going on. Maybe there is a mass there. Maybe there's a tumor there. Maybe there's been some cerebral trauma. There's a lot of times in these traumatic brain injured patients, you'll see seizure activity. So what I mean by a syndrome is basically think of it as sort of a clinical manifestation of maybe one of these things, other things that's going on, like trauma, like a mass there, something like that. Does that make sense? So think of it almost like a symptom or a clinical manifestation of one of these other neurologic problems.
Right, but we did call epilepsy a syndrome as well. So
It's basically just the way that you can think of epilepsy as a syndrome of something is just sort of a group of clinical manifestations. So in terms of epilepsy, just right, exactly. There is no underlying cause for epilepsy. So that's why sometimes you'll hear the differences between sort of like a disease and a syndrome differentiated by, can you pinpoint pathophysiologically what's going on? And if you can't, it's hard to say that it's actually a pathologic disease when there's no structural abnormalities going on. So then sometimes they'll refer to things as syndromes. Does that make sense? Okay. All right. So really, when looking at this slide, given what I just said, a seizure can basically be any disorder that, or I should say, a seizure may be caused by any disorder that alters the neuronal environment, the neuronal firing and electrical activity of the brain can cause a seizure. Therefore, theoretically, any one of us at any time, really, could experience a seizure, right? If there's something else neurologically going on. So here's some of those things that I just mentioned here. Lesions, some sort of maybe biochemical disorder. Maybe there's some type of biochemical or like electrolyte imbalance. Sometimes you'll see a lot of neurologic things and sometimes even seizure activity with like hyponatremia, right? So some biochemical factors that might cause this. The one thing that I, for some reason, forgot to put up here under etiological factors, another good reason why you might see seizures is febrile seizures in the pediatric population. Again, febrile seizures can happen pretty commonly in kids with high fevers. So any fever above like 103 degrees Fahrenheit in a kid may actually cause a febrile seizure. Now, it's pretty common in the pediatric population for seizures to occur with fever. Obviously, it's pretty darn scary, or would be pretty darn scary as a parent to see this happening, but it actually is pretty common, and a pretty common reason for why you see seizures in children. It means nothing in terms of neurologic dysfunction or a neurologic alteration in these kids. It literally can just be brought on by seizure or by fever. Once that fever is taken care of, they don't have seizures anymore, and there's nothing, you know, in terms of the future, there's nothing wrong with them in terms of their health. So that's another etiologic factor for why that might occur. The way that we sort of classify seizure disorders are classified in different ways. They can be classified on sort of the clinical manifestations, how it looks, you know, how it actually presents in the patient. The site of origin, meaning what part of the brain is being electrically sort of altered to actually cause a seizure. We can sometimes classify seizures depending on what their EEG looks like, so the electrical encephalogram, what it actually looks like while seizure activity is occurring, and how they respond to therapy. Is it, you know, do they respond well to seizure activity decrease with anti-epileptics like Dilantin or something like that? So, for example, epilepsy now is really considered to be so I talked about all these different reasons why seizures might occur. Going back to this whole epilepsy sort of conversation, epilepsy now is considered to be the result of probably some interactions of a lot of different things. So maybe there's some sort of genetic mutation or genetic predisposition that someone might have that then, in combination with environmental effects, causes sort of an abnormality in the way that the brain is wired, and then causes these increased electrical activities, this increased charge of electrical activity in the brain. So for example, I don't know if anyone's ever heard, and it's actually not a myth, it's true, that like strobe lights or flashing lights can actually cause a seizure in someone with epilepsy. Again, that probably is going back to some of this information here regarding someone might have sort of a genetic mutation or a genetic predisposition, but it's really only when they come into contact with something in their environment that it causes that sort of, for lack of a scientific way of saying it, that haywire electrical activity of the brain. Okay, so that's just kind of another example of the different ways that seizures can sort of be brought on, the different ways that seizures can sort of manifest. So different types of seizures you'll certainly see in different patients. But again, for the purposes of today, when we're talking about sort of the pathophysiology of seizures, we're going to talk about specifically tonic-clonic or generalized seizures. Okay? So the pathophysiology of a tonic-clonic seizure has two phases, right? You have the tonic phase and you have the clonic phase. The tonic phase of seizure or seizure activity is that initial sort of really quick, really all of a sudden sort of muscle contraction with increased muscle tone. So if you're actually looking at a patient and they're now entering into this tonic phase of a seizure, this is when you see that person walking along the street normally. All of a sudden they stop, their body seizes up, and they fall to the ground, right? That is the tonic phase of a seizure, of a tonic-clonic seizure. So, and pathophysiologically, what causes that is excitation of a bunch of different areas in the brain. So subcortical, thalamic, and sort of brainstem areas get overexcited and sort of overactivated during this tonic phase of a seizure. Then what quickly sort of follows that phase is what we call the clonic phase. So this is now that sort of stereotypical visualization of someone having a seizure, and that you had that alternating contraction, relaxation of muscles, right? And the reason that this happens is because, so you've had initial sort of excitation of subcortical, thalamic, and brainstem areas in the brain initially with the tonic phase. Now what happens is that you have inhibitory neurons that sort of get activated during the clonic phase that kind of starts to try to turn off that electrical activity. So that's why you see that sort of stop-start, stop-start, stop-start sort of activity, because of these inhibitory neurons that are trying to kick in and actually stop or turn off that excess electrical activity. So seizure discharge then during the clonic phase sort of intermittently interrupts that tonic phase, causing that intermittent muscle contraction that gradually slows down and then stops. Anyone know what, pathophysiologically speaking, actually causes a seizure to stop, that actually causes this clonic phase to eventually sort of completely stop that muscle contraction and relax and stop? Anyone know what causes the seizure activity to actually end and for the person to stop convulsing? Anyone know? Mm-hmm. Right, they deplete a lot of different types of stores. Neuronally, calcium, and also just sort of like the electrical activity just basically metabolically wears out that part of the brain, wears out that tissue, and wears out those neurons. Very good, very good. So basically what ends a seizure at the end of this clonic phase is that sort of the term they use, the epileptogenic neurons, so the neurons that are involved in the seizure, basically just get exhausted. They deplete their oxygen stores, deplete their ATP, deplete calcium, basically deplete all of their metabolic sort of functioning because of how much energy a seizure takes. How much energy is needed for seizure activity to actually start. It eventually does wear out. So during this tonic and clonic phase, oxygen is consumed at extremely, extremely high rates. This is very, very high metabolic activity that occurs in tissue during seizure activity. So obviously a lot more oxygen than normal is needed during these types of really crazy high metabolic activity in the brain. So much so that it's almost like 60% more than normal. oxygen is needed and used up in the tissue during this period of time. So obviously you can imagine then during the seizure activity, because of this increased oxygen consumption need, how much extra blood flow gets to that area as well. So it does for a short period of time, the body does for a short period of time sort of compensate for that increased oxygen needs and increased energy needs, and does get more blood there for those metabolic reasons. The problem is that after a very short period of time in a seizure, the oxygen stores get completely used up because there's so much energy needed. So then what happens? On a cellular level, when you're getting blood to the area, you're getting blood to the tissue, but there's such a high need for oxygen because of the high activity in that area, and all the oxygen gets used up, then what happens on a cellular level? Think about all of the conversations we had last semester. What do you think? I heard murmurings. What's that? I just didn't hear what you said. You don't know? Anybody else? You're going to basically, first things first, you're going to deplete your oxygen stores, so you're going to switch from aerobic to anaerobic metabolic activity, right? And then what happens when you switch from aerobic to anaerobic activity? Well, first of all, the amount of oxygen or the amount of energy you can make goes down. And then what happens to the tissues? What's produced in lactic acid? Very good. Lactic acid accumulates in the tissue when you have decreased oxygen and basically lack of oxygen. So that also these people can become very sick as well because of lactic acid accumulation in that. That's why people with prolonged seizure activity, so a seizure that won't stop, and there's a term for that, I'll write that on the board, it's status, it's sort of a Latin word, status epilepticus. This is a patient who the seizure activity doesn't end, it just keeps going and going and going and going, and it doesn't sort of wear itself out the way I said usually happens at the end of a clonic phase. Can you see it? Because the neurons just keep firing electrically. And even though they've worn out all of the metabolic oxygen stores, the neurons themselves keep firing. So, the firing of the neurons themselves, right. So, can you imagine what that does to the brain and to that patient in general? So basically, you set yourself up in a situation of status epilepticus where the clonic phase does not end. You set yourself up for basically potential brain damage and injury because of the lack of oxygen to that tissue. Basically, major hypoxic injury can happen. Yeah? Yeah, so one of the big classifications or big classes of drugs that are used very heavily actually in the middle of seizure activity is benzodiazepines. So you're like Ativan, those types of medications. I've definitely seen patients in status epilepticus, not only in the ER, but then they get moved up into the ICU being on literally like an Ativan drip to try to decrease that stimulation in the brain. But I've also seen patients, I think I was actually even in nursing school. I wasn't really even out practicing yet, but I had a rotation in the ICU. I had a patient who was a young woman who was currently in status epilepticus and basically had major brain damage done because of a major hypoxic injury that occurred during the seizure that just would not end. So that sort of should help you sort of visualize the issue in terms of the way turn up the volume on metabolic activity, oxygen need, blood flow needs that a seizure takes and what it does to the brain tissue and to that electrical firing. So hopefully that makes a little bit of sense to you. Okay. So that's kind of the pathophysiology. Now let's talk about what it actually looks like, right? So what are we concerned about? What are we thinking about? What are we hearing or seeing in our patients that are actually experiencing a tonic-clonic seizure? Well, first of all, and I kind of have these out of order. I really need to sort of put the prodroma before or RS. So if you want to, make a little note or draw an arrow or something, it makes more sense if you put the other one first. So let's start with the prodroma. The prodroma is a very early clinical manifestation occurring hours to days before someone might actually have seizure activity. So you might hear a patient complain of sort of just feeling malaise, maybe a sort of vague headache, maybe just feeling not quite like themselves for several hours to days before the seizure activity may actually occur. Then, pretty immediately, right before the seizure activity occurs, you'll a phase called the aura. Anyone heard of someone having a sort of epileptic or just a seizure aura? So it does immediately precede the onset of a generalized tonic-clonic seizure. And it's really these strange sort of sensory experiences that a patient might have. So sometimes I've heard patients complain of having like a strange taste in their mouth or smelling something. I had a patient who said that right before a seizure, she would smell toast. Like she would literally smell like, toasted bread. Sometimes it can be something that they're hearing. Sometimes it can be some weird sort of sensory, like numbness and tingling kind of things. Or sometimes they really can't pinpoint how it feels at all. They just feel weird. And then like literally maybe a few seconds to a minute after that, tonic-clonic seizure begins. So again, I would sort of put the prodroma as maybe several days leading up to a seizure, and the aura maybe several seconds to a minute or so leading up to the seizure. Yeah.
So growing up, I had migraines really bad.
Mm-hmm.
I had the prodroma.
Yeah, you hear that with migraines sometimes too.
The aura as
Yes,
well.
yes.
Are there any like neuron connections?
Well, I mean, migraine headaches also have to do with sort of excitation and sort of weird wiring of neurons as well. So some of the pathophysiology of that is similar. Obviously, then with the migraine, it sort of ends there, and you just sort of have the headache and sort of that aura sort of things, and doesn't go into that overexcitation of the neurons to actually cause convulsions. But the pathophysiology is similar. Yeah. Mm-hmm. Good question. Mm-hmm.
When people, if they know that they're prone to have seizures first because they have epilepsy,
Yes.
is there anything that they can do during the prodroma phase to prevent seizures?
Well, hopefully they wouldn't even get to, like let's say there's someone has epilepsy. Hopefully they wouldn't even get to that point of the prodroma or the aura because they're being compliant with their anti-epilepsy medication. Yeah, yeah. So that's kind of my answer to that, is hopefully they wouldn't even get to that point. Then, after the prodroma and the aura, you get into that, that pathophysiology of that excitation of the neurons, and you get into that tonic-clonic phases of the seizure. Now, after the clonic phase has basically, the neurons have just become exhausted, those neuroepileptic sort of neurons that are partaking in the seizure just basically get exhausted and the seizure stops. You go into the last phase called the post-ictal phase. And this is immediately following seizure activity when the convulsions have stopped, when the tonic-clonic shaking has stopped. In this post-ictal phase, patients appear to basically be completely, their whole body, not only somatically but also neurologically, are just exhausted. They have been completely wiped out, and they basically look like they're in a deep, deep sleep. Has anyone seen anyone sort of post-ictal? I mean, they're out. So much so out that sometimes I've seen people like desat, because they're so asleep that your oxygen saturation kind of starts to decrease because they're not taking good, big, full, deep breaths and protecting their airway. And again, pathophysiologically speaking, the reason that happens is because their body metabolically is so completely worn out. I've also seen patients in the post-ictal phase not only be super drowsy and very hard to sort of wake up out of a sleep, but also really confused. So really sort of irritated, wanting to, pull at things, confused about where they are, just kind of combative. I've also seen patients sort of that way in a post-ictal phase as well. Also, during this tonic-clonic phase, going back there for a second, sometimes it's very common to see sort of incontinence as well. So you can see someone lose bowel and bladder function during the actual convulsions of the tonic-clonic phase. That's pretty normal as well. So, if anyone's ever seen seizure activity or has experience with it, maybe clinically, what kind of things do we have to do as caregivers? And we actually call these like, seizure protocol or seizure, what do we do in terms of protecting patients during specifically the tonic-clonic phase? What kind of things do we do for seizure precautions? Yeah.
You want to make sure that there's nothing like around there.
Okay, so clear the area, right? Put them on their side. Why? So we'll get back to those things. Why put them on their side? Aspiration risk of vomit, right, exactly. And why do we say, there used to be a big wives' tale of like, put a tongue depressor or something in their mouth so they don't swallow their tongue during a convulsion. Well, first of all, they're not going to swallow their tongue. And why is it extremely dangerous to go putting your finger in someone who's actively, they'll bite the crap out of your finger. Exactly, right. Like, Right, pad the side rails, put them on their side, clear the area, have suction close by. Also, maybe some oxygen because they will maybe desat during that experience. Very true. What else did you say? Well, seeing how long it goes, right? Very good. Obviously, watching their vital signs. It's not uncommon for them to desat and have some sort of oxygenation issues during the experience. Yeah. They may bite their tongue, but they're not going to swallow. So they're not going to swallow their tongue and have like a major airway issue.
Right.
Yeah.
So could you still do something
I would not. I would not put anything in their mouth. No. The other thing, so we said basically everything that I had sort of down here. Obviously, also, if you have a patient with a known seizure disorder and they're like in the emergency room, I'm having some benzos in my pocket. I'm having Ativan in my little pocket right here, so that as soon as something does occur, I have something right there to sort of be able to give them IV. Again, according to your unit's protocol, if that's something warranted or not. And then obviously a lot of, once the patient's not actually having a seizure, a lot of patient education. If this is a known epileptic patient who's maybe not compliant with their medications, talking to them about medication compliance and sort of educating the patients regarding their medications as well. The other thing is, if you've got a patient in the hospital, like let's say a patient in the hospital coming in for seizure activity who maybe is not compliant, what else would you maybe not want them to do? Drive. But while they're on your watch on your floor in your bed, don't get up and walk around and go to the bathroom. Let me share with you a little story that I learned regarding this. So I was still on orientation. I'm like a new grad on orientation with my preceptor in the ER in St. Louis. Had this patient come in who was non-compliant with his medication and was driving a vehicle. Ended up having a major motor vehicle accident on the interstate in St. Louis. Came in via EMS for this motor vehicle accident. Luckily, miraculously, he was not all that badly injured from his car accident. So really most of the care that we did for him in the ER was trying to get him therapeutic back on his Dilantin to sort of decrease these risks of having another seizure. And he had been with me like all day, like my entire shift. Was completely fine, like I said, nothing sort of, no major issues regarding the car accident, no seizure activity. We did start him on Dilantin, so he had currently IV Dilantin infusing via his IV. And of course, all day, he wanted to go out and smoke. He wanted this, he wanted that. He wanted to get up and go to the bathroom. And clearly, I'm not going to let this man who just had this seizure and who's not therapeutic on his Dilantin get up and walk around in the hallways. So, I had done everything perfectly. I had my padded side rails and the Ativan in my pocket and, suction and oxygen nearby. But, after a while, literally he was there for like 5, 6, 7, whatever hours. The man was wearing me down. And he wanted to go to the bathroom. And I kept saying, I can't let you get up and go to the bathroom. So finally, after like 8 hours of him not having a seizure and Dilantin was currently infusing, he asked me again, sweet talked me. And so we came to this compromise that I'm not going to let you get up and walk down the hall to the bathroom, but how about I give you this plastic, bedside urinal, and you can sit here on the side of the bed and urinate here so that you're not trying to like lay down in bed urinating like you have been all day. So we did. Okay, gave him the urinal, closed the curtain, walked out. I went back to my preceptor and started looking at other patients and, doing other things. Well, when you get that like gut feeling, like something's not right, listen to it. So I'm like, let me just go back and check on him real quick. So I go back to his room, open the curtain a little bit, stick my head in, Mr. Smith, you doing okay? And as I do that, he's sitting on the side of the bed and he looks up at me and has this really strange look on his face, which now I know is the aura, right? Completely proceeds to go into this full clonic-tonic seizure. Of course, he's fully having a seizure, right? So he falls off the bed. He's having a seizure, so cannot catch himself, obviously. Whacks his head so hard on that concrete floor, covered up by that little nothing tile, right? Knocks his head so hard on the floor, busted open, huge lack, right? Blood everywhere, on the walls, on the curtain. Now he's laying on the floor, seizing in not only his own urine, because he has now dropped the, yeah, it just keeps getting better, seizing in his urine and now blood. And I'm like, oh my, why did I become a nurse? I think I should have like been a florist or work at a bakery or something. Why did I do this? Clearly I'm not competent. So anyway, I'm thinking here he survived this major car accident, 8 hours later, and now he's going to have this huge epidural bleed because of me, right? Because I let him sit on the side of the bed and urinate. So he, of course, then we get him to the CAT scanner to make sure he doesn't have some major whopping bleed. He didn't. He did have this huge laceration from hitting his head on that concrete floor, all the way across his forehead, like down to his, I don't even remember how many sutures he had. So it was a nightmare. And I literally was like, maybe I shouldn't be doing this. But I share it with you because luckily he was okay. And he honestly took a lot of ownership over the situation as well, because he knew he shouldn't have been doing that. He knew he shouldn't have gotten up. Ended up, he was all right. He had a major laceration, but neurologically speaking, he was fine. But I will never, ever forget that. And I share it with you because, we make mistakes and we try to learn from our mistakes and make good decisions. And so I share that with you so that if you ever have that situation, you never let that patient get up out of bed. I don't care how uncomfortable you are or how hard it is to pee while you're laying flat on a stretcher, don't get up. So that's my story and my visualization for you for tonic-clonic seizures and the care and the sort of, seizure protocol or precautions that we take. So I continued to be a nurse, and I didn't stop and become a florist, and I'm glad I didn't. But, I'm just sharing that with you so that we learn from our mistakes and we don't do those things again. So there you have it. All right. So that is the end of our seizure discussion, end of our content of Chapter 14. And now we're going to move on to Chapter 15. And if you see here, really the title of Chapter 15 is Disorders of the Central and Peripheral Nervous System and the Neuromuscular Junction. I will tell you honestly, we're going to spend most of our time talking about disorders of the central nervous system. And then, like I said, at the end of this lecture, you'll see some information regarding neuromuscular junction, like talking about multiple sclerosis and ALS. We probably honestly won't get to that today. We'll finish up talking about that on Monday before we talk about the kiddos. Okay? So Chapter 15, focusing mostly on disorders of the central nervous system. Here are your objectives. All right. So, in sort of piggybacking with our conversation regarding, increased intracranial pressure that we had on Monday, we talked more sort of clinically about it, right? What increased ICP is, what it looks like, some reasons for it, what it may look like clinically, how it manifests in our patients. Today we're going to talk more specifically about some reasons for it. So, some actual, reasons for increased ICP. So we're going to talk a lot today about brain trauma, so traumatic brain injuries, and also spinal cord trauma or spinal cord injuries. So we'll start here with talking about TBIs, traumatic brain injury. So a traumatic insult to the brain that really produces obviously physical problems to the tissue of the brain itself, but also intellectual, so more sort of intellectual cognitive problems, emotional problems, social problems, and vocational issues or problems. So obviously besides the actual pathophysiology, but besides the sort of physical, structural kind of problems that obviously a TBI may occur, or may cause. You also have to think about sort of all the sort of strain emotionally, socially that might have on the family as well. So this is a person that even if they do recover, quote unquote, recover from a traumatic brain injury, they may not be the same person, right? That attorney may still not be able to work as an attorney, right? So we have vocational changes. That breadwinner of the family may no longer be the breadwinner. So all of the strain socially, emotionally that might have on the patient, but also the family and the caregivers themselves. Obviously, a lot of different reasons for why brain trauma may occur. Car accidents, like I just mentioned on this seizure patient I had, falls, sports-related injuries. There's so much talk now about concussions and head injuries in football. And then obviously violence, gunshot wound to the head, stabbing, whatever it may be. You can certainly see a lot of traumatic brain injuries in that respect as well. Those at highest risk for TBIs are children under the age of 4, Probably because, they're still kind of learning to walk and learning how to sort of, gain motor function and motor control. Adolescents, like 15 to 19 years of age, probably, again, because of maybe their lack of inhibition. So they're diving into pools they shouldn't be diving into, jumping off of things they shouldn't be jumping off of, driving fast, those types of things. And then adults 65 and over are also a really high risk for traumatic brain injuries as well. Again, probably because of fall risks. Did you have something you wanted to add? Shaken babies, that's a good one too. Right, that's a really high sort of population that's at risk for TBIs as well. Very true, very true. Thank you. Okay, so when discussing TBIs, you really can categorize them as closed traumas, so closed head injuries, and open head injuries, okay? So that being said, I'll say first, damage can be done, especially now when talking about closed trauma, because that's what I have on this slide, but also in more open trauma as well. Damage can be focal, and what I mean by focal is that the damage is done in a very localized area to the tissue of the brain itself, so affecting one distinct area of the brain only, or more diffuse damage to the brain. And by diffuse, I mean sort of diffuse axonal injury involving more than just sort of one area of the brain. The example of shaken baby syndrome would be a really good example of a closed, diffuse brain injury because of that sort of shaking and shearing of those axons in the brain as the brain moves back and forth and hits the inside walls of the skull. That would obviously be more of a diffuse damage to like large areas of the brain versus like head versus windshield, and you have a very focal area of the brain being damaged. So a closed head injury is what we also can refer to as sort of blunt or non-missile. Missile means something sort of penetrating or moving fast, through the brain. So this is not a missile injury. This is a non-missile injury. So usually happening because the head strikes either a hard surface, like a windshield or something like that, or helmet-to-helmet contact in football, that kind of thing, or something is rapidly moving by the head and strikes the head, okay? Now, in a closed trauma, the dura, that protective covering around the skull and brain, remains intact, and the brain tissue is not exposed to the external environment, right? It's just all closed inside the vault of the skull. And, a closed injury can be focal, or a very localized injury, or it can have more diffuse, generalized damage done to the tissues. And we'll talk a little bit about both of those in just a second under the umbrella of closed trauma. The most common type of brain trauma usually is pretty mild. In most cases, maybe some of you, even sitting in here, have had some type of closed head injury. And a really good sort of example of that would be like a concussion. That's considered a closed, sort of blunt head trauma. So again, head injuries can be closed or opened, and we're going to talk about the two different kinds right here. So regarding this definition now of closed trauma, give me some examples of what may cause a closed head injury. Give me some reasons or some, a hard hit in sports, right, good. Motor vehicle accident, head hitting the windshield, very good, very good. Okay, so we'll come back to that in just a second now, but let's briefly discuss and sort of define open. So an open head trauma is or penetrating or missile trauma is something where the actual mechanism of injury breaks the dura and breaks the skull and exposes the cranial content to the environment, okay? Usually these types of injuries will cause primarily a pretty focal injury, right in that area of the skull fracture, right in that area of the penetrating bullet or knife or whatever into the skull and into that tissue. So again, skull and dura have been penetrated in an open trauma. Now, given the examples I gave, maybe a stabbing, maybe gunshot wound to the head, maybe something like that, given that the dura and the brain matter is actually now, there's a conduit between the inside of the skull and the outside environment, what are we really concerned, well, we're concerned about a lot of things, but what's one thing that we're concerned about in an open head trauma that we're not so concerned about in a closed head trauma in this particular type of patient? Infection. Very, very good. We are really worried about infection in open head traumas. Very, very good. Okay. So, let's talk a little bit about the mechanisms of brain trauma and TBI and brain damage. So, primarily what happens in terms of mechanism is that the damage is done or caused by the actual impact of whatever is hitting the head. So, it involves neural injury, so it actually, obviously damages the neurons, primary glial injury, and vascular responses. So obviously blood vessels will be damaged and responding to this primary sort of insult as well. Secondarily, what you'll see is indirect consequences of that primary injury. So it can include a cascade of a lot of different cellular and sort of metabolic responses that those cells have in the brain to that damage. There could be altered blood flow to that area. Obviously, if there's altered blood flow, you're going to see issues with, lack of oxygen getting to the tissue, so hypoxic and ischemic changes. Again, inflammation is going to be huge, right? Just like if you'd bonk your arm or you'd bonk your leg, right? You're going to see a lot of swelling and inflammation in that area. And again, what did we talk about on Monday? Well, why we're so concerned about inflammatory responses in the brain. Why are we so worried about that? Because of the pressure, because of the increased ICP. That skull is fixed, usually, and doesn't allow for a lot of excess inflammation and swelling. So you'll see cerebral edema and increased intracranial pressure as usually sort of the secondary injury to that initial primary insult. And then tertiary brain damage or tissue damage really isn't neurologic damage at all. Really what they're referring to in terms of tertiary is that these are like things that would develop days or months after some sort of traumatic brain injury, so usually resulting from more sort of systemic complications or complications from like immobility. Right? So things like infections, fevers, all those sort of complications of the initial injury are what they refer to as tertiary damage, but it's not really neurologic damage. Does that make sense? It's more complications of the injury or complications of immobility is what tertiary damage really refers to. Okay. So we've talked about the difference between open head injury and closed head injury. We've talked about the different sort of mechanisms of damage. Now let's talk specifically regarding the two definitions of sort of focal, specific, localized brain injury, and then we'll spend some time talking about more diffuse injury. So focal brain injury, primary brain injury. Usually, like I said, it's a very sort of specific, grossly observable brain lesion, right? It's in one specific spot because of whatever struck the head in that area, etc. So the force of impact typically produces contusions. So blood leaking from that injured blood vessels, inflammation in that area, that's all going to be pretty localized. Now, usually these localized focal brain injuries are referred to as contusions, right, or hematoma. And we talked about some of those when we talked about sort of that those meningeal spaces and those layers of the brain. I think it was 2 classes ago. So regarding that epidural space, that subdural space, we talked about how there's bleeding that sort of can occur in those meningeal spaces to cause increased ICP and things like that. So this is exactly, those hematomas that we talked about already is the exact sort of great specific example of a focal brain injury, right? You could literally look at a CAT scan and say, there's the hematoma, right? The only hematoma that we really didn't talk about so far is intracerebral hematomas. So we talked about where an epidural hemorrhage occurs. We talked about where the subdural hemorrhages occur. We didn't really talk about intracerebral. And here's a good picture of that. So here, again, is sort of where that epidural hematoma would occur. And again, remember, it usually happens because of maybe some sort of skull fracture, because those arteries that sort of run in, those grooves of the skull obviously get damaged with the skull fracture and then bleed into this epidural space. Subdural hematoma, you can kind of see the space that would be. But an intracerebral hematoma is actually in the tissue, actually in the brain tissue itself. So with intracerebral hematomas, they really can increase the intracranial pressure because it compresses the brain tissue. It almost acts like a space-occupying mass, right? It actually almost acts like a tumor in there because it just sort of, as it bleeds, it just pushes more and more and more on the actual tissue of the brain. And so it actually, can really sort of push on other structures in that cerebral space. So again, just kind of giving you some different reasons or some different locations of hematomas that would act as a focal brain injury.
So does the blood, another silly question, but does the blood kind of diffuse into that tissue, or is it creating like a pocket?
It almost, think of it as like a pocket.
Okay.
Yeah, so see how here, how it's like in these little pockets, and it just pushes that tissue aside?
Since there's no membrane, it still just does
Yes,
that.
it still basically acts as like a pocket, like a space-occupying lesion that just pushes that other tissue away. Okay, does that make sense? Okay. All right, so yeah, so focal brain injury really does usually result from compression of the skull at a certain point of impact, and then once it starts to bleed or once it starts to become a contusion or a hematoma, it just pushes that tissue aside. Now, in regards to either epidural, subdural, or intracerebral hematoma, really, especially if this bleeding continues and it doesn't just kind of like turn off by itself, really the only way to fix this is surgical. You have to go in and evacuate that blood and stop the bleeding, and then obviously get rid of that blood that's causing that pressure. So that's how we would sort of treat and look at this example of a focal, very localized brain injury. All right. Now, another issue when talking about focal brain injuries is this issue of a coup contra coup type of injury. Let me tell you a little bit about what this is. So, even though a focal brain injury is sort of defined as one specific localized area of impact on the skull that then impacts the tissue underneath of it, it can also have more secondary effects and more diffuse effects as well. So let's talk a little bit about what this means. So a coup injury is the actual impact against the object. So in the example, clear-cut example I can give you is head versus windshield, right? The coup injury is the impact against the object. So it's the forehead against the windshield, right? It's the site of impact and the direct trauma to the brain. You will sometimes, because of the force, that sort of like inertial force of the brain slamming up against the side of the skull and hitting that object, you will start to see some shearing forces to those subdural veins. So that's where you start to get into risk factors of having like a subdural bleed because of that shearing of those veins inside that subdural space. But then, not only do you have the impact against that actual object that's the problem, you have the impact within the skull that's also the problem. And this is what we refer to as the contra coup injury. So yes, you've got the initial injury of boom, impact to the brain. But you've also got the impact of, and as you see here, the site of impact from the brain hitting the opposite side of the skull, right? So the perfect example of a coup contra coup injury is a head versus windshield and then sort of whiplash back, right? So you've got that initial impact, but then you've also got the brain. The brain is sort of this gelatinous type of tissue inside that hard fixed space. So with inertia, as you hit the windshield, that brain's going to all slam up against the inside of the skull, and then it's going to whip back and slide back to the other side and hit the back side of the skull, right? That's the contra coup injury. Now, that's not a focal, localized injury. It's more of a diffuse injury because what happens now when that head sort of whiplashes back during the contra coup injury, you really have all this sort of shearing going on inside the brain. It slaps back, then it slaps forward, right? And the brain just sort of jiggles inside the skull and slams up against the walls of the skull, causing major shearing forces not only to the tissue and to the blood vessels, but to the neurons themselves. So in this type of injury, you have both sort of the focal type of injury in terms of the coup phase, but then you also do have diffuse, more generalized damage done to the brain during the contra coup phase of literally the brain just sort of sloshing back and forth inside the skull and slamming up against the walls and sliding over each other. Does that make sense? That's a coup contra coup injury. Great example of like head versus windshield and then whiplash. And here's a picture of that. So the initial coup injury is just the head hitting the windshield. The contra coup, and see how these arrows are sort of moving inside the head of the tissue, sort of sliding back and forth on each other, that's the contra coup. So it's really a local injury of the head hitting and then diffuse injury of the contents sliding around inside the skull. Any questions about that? Okay. You also can discuss focal brain injuries when talking about compound fractures of the skull, right? So where you actually do then have open communication between the cranial contents and the external environment. Now, it's not a true sort of open brain injury in that the skull hasn't been cracked and you can sort of like see gray matter, through the skull. But there has been some type of subtle communication, subtle opening between the cranial contents and inside the skull and the external environment. And so one really good example of more of a subtle type of compound fracture is something called a basilar skull fracture. This is where the base of the skull gets fractured. Now, if I would probably ask you all right now, put your hand on the base of your skull. Where do you think the base of your skull is? Exactly. You think right back here, right? But where the base of the skull actually is, you can't really put your finger on it. So if you think about it, it's sort of like behind your nose and sort of behind your sinuses, right here. There's a thin, like if you would cut my face in half, please don't, but if you would cut my face in half and sort of open it up, you would see this very thin bone that sort of rests right under my brain, right here, inside my head, okay? So I can't really put my finger on the base of my skull. It's inside my head, like behind my sinuses, like at this plane right here, okay? So the way you can fracture your basilar skull is usually by some sort of hard hit to the back of your head. Like, someone takes a baseball bat to someone and hits them back here in the back of the skull. There are very specific sort of hallmark assessment signs of someone with a basilar skull fracture. They consist of something called battle sign, raccoon eyes, and an actual cerebrospinal fluid leak. So the first one, battle sign, and actually I will scoot forward here a couple of slides. There we go. A battle sign occurs because of, you've created a fracture to the basilar, the base of the skull. It's going to bleed, right? The issue is, though, is that blood really has nowhere to go back here in the sort of the base of the skull inside your head. So the blood leaks to places of least resistance, like little pockets or little cavities where the blood just kind of drains into because there's not a lot of pressure in some of those areas. One area that bleeding from a basilar skull fracture, one area that it'll run is this mastoid process area here behind the ear. So this is called battle sign. See this bruising on this mastoid process here of this person? They did not get hit behind the ear. There has been no damage done to their mastoid process. The reason they're bruised there is because of the bleeding inside their head to that little pocket, to that little area of least resistance, and you see bruising there. Another area where the blood sort of runs is sort of the periorbital area, sort of the periorbital cavities around our eyes. And that's what causes this sort of raccoon eyes effect. Again, this person did not get hit in the eye. She has a basilar skull fracture, and that blood is leaking and oozing into those periorbital sort of cavities. So these two signs, battle sign and raccoon eyes, are really good clinical indicators of some type of disruption in that basilar skull. The other really good sort of indicator of a basilar skull fracture, as I mentioned on the previous slide, is a CSF leak, a cerebrospinal fluid leak. Again, because what happens is, if there is actually disruption of the skull, it's a thin little part of the bone, but if there is actually disruption of the skull in this area, and there's like a little bit of a break in that skull, it can actually sort of break and poke into the ventricular system of the brain, and allows for CSF to leak right into sort of the sinus cavities, right? So I've seen patients come into the ER who have a basilar skull fracture. And again, oftentimes with a basilar skull fracture, they're A&O times 3, they're talking to you. Obviously, they're probably complaining of a headache, of head pain, but it's not like they're unconscious, right? And I've had a patient laying in the stretcher say to me, I just feel like I have this constant drip in the back of my throat, like almost like post-nasal drip. And I keep feeling like I need to clear my throat, like I have this drip in the back of my throat. Okay, if I know that someone's gotten hit to the back of the head, and now they're saying like they have post-nasal drip, I'm concerned that they actually have a CSF leak into their sinuses and into sort of their oropharyngeal areas. I've also seen patients complain that they just kind of have like a runny nose, like a clear sort of just drainage from their nose. I'd also be really concerned given their history that we're talking about a CSF leak. Again, these types of patients, because now you have this probable open conduit between their nasal passages and their brain, right? Because the skull has opened up a little bit and allowed for open communication between the ventricular system of the brain and their sinuses. That being said, these are not patients for NG. These are not good candidates for NG tubes. Because literally, you could have put an NG tube into their nose and the NG tube could go up into their brain. Because of that break in that small little bone that lays right behind there. So that's a good sort of clinical picture of someone with a basilar skull fracture. Any questions about that? Another really good example of a focal brain injury that now also would be considered open, right, just like a basilar skull fracture is considered open focal brain injury, is some type of missile injury. So these would include things like bullets into the skull and into the brain, rocks, shell fragments, knives, I mean, literally anything, right, that penetrates the skull and penetrates the dura and gets into the brain. The mechanism of injury usually for an open missile injury kind of thing, not only is obviously the crush injury to whatever the missile touches, so obviously injury to the skull and to the brain itself from, let's say, a bullet entering into the brain, but also a lot of times these missile injuries have such high velocity to them, like a gunshot wound or something like that, that actually not only does it cause that sort of focal injury, but it also, as it passes through the tissue, pulls and stretches the tissue, the blood vessels and nerves, and sort of pulls and causes a stretch injury to that tissue as well. Obviously, missile injuries have a very high degree of mortality, way more so than like a basilar skull fracture. And they usually say sort of a general sort of rule of thumb, especially with open sort of missile injuries to the brain, that especially if the missile crosses the midline of the brain, you even have a worse prognosis. So if you have a bullet that just kind of gets lodged on one sort of hemisphere of the brain, that's a better prognosis than if it goes through both hemispheres and crosses the midline. That has a worse prognosis. And again, here's the pictures of the basilar skull fracture. This is a little graphic, but here's a pretty good image of a missile injury. This is someone's head that has sustained a gunshot wound to the head. And you can see here that I will honestly tell you, just from my experience, this is probably the exit wound. So you always have an entrance wound, and then if it actually crosses midline and goes through the other side, you'll have an exit wound as well. Entrance wounds are pretty small and sort of star-shaped, but the exit wound has sort of a bigger sort of blowout effect because, again, all of that shearing and tearing as it moves through the tissue. Again, higher mortality rate when it crosses the midline and actually exits out of the head. I had a patient in St. Louis one time, a gunshot wound to the head, gang-related activity, and we were moving him from EMS stretcher onto our stretcher in the ED. And there's always, especially if there's some sort of head, neck injury, you always want to maintain C-spine immobility, right? So that you're, picking up the head and shoulders and moving it over to onto the stretcher to make sure you don't have like a C-spine injury as well. And I was the one at the head, and I sort of reached under his neck and head to sort of move him from stretcher to bed. And he had a gunshot wound basically like right to the forehead. And as I picked him up and moved him over, he did not have an exit wound, but there was so much shearing and trauma done to the tissue inside of his head and skull that when I put my hand underneath his head, the back of his head just felt like mashed potatoes. His skull was intact. I mean, the back of his head was intact, but it was soft as I moved him from table to stretcher. Major missile injury, major both focal injury, but then also, all of the sort of diffuse shearing and tearing of the tissue inside the skull as well. So again, that's a really good example of missile injury. Okay, so now we're going to move from sort of the more gory, graphic, sort of focal, localized types of injuries to more of a hard to sort of picture kind of injury, a hard to sort of visualize it in your head kind of injury, and that is diffuse brain injuries. So diffuse brain injuries, if you would put someone that has sort of diffuse axonal damage into a scanner, what's their CAT scan going to look like? Anyone know? Normal. right? It's not like you just put someone in who's got a big hematoma or someone in who's just had this major missile injury to their brain. Obviously, if you put some of those people with these localized focal injuries into the scanner, you're going to say, yep, there's the epidural bleed, or yep, there's the bullet, right? In someone with a diffuse brain injury, where it's more because of inertial forces and more of sort of a shaking kind of effect to that brain inside the head, there's not a lot of structural abnormalities seen radiographically. What the damage done in diffuse brain injuries is that pulling and shearing and stretching and snapping of neurons and axons, right? That does not show up on scans. It's not like there's a big old honkin' bleed in there, right? It's just more on a cellular level, the damage done to the neurons and to the axons. So the kinds of injuries you see that causes that diffuse axonal injury would be like shaking inertial kind of damage, like shaken baby syndrome. Acceleration, deceleration kind of forces, again, shaking that tissue up inside the head. And what you see is axonal damage, shearing, tearing, stretching of nerve fibers. Now, the severity of a diffuse brain injury, and we specifically say sort of diffuse axonal injury, really does correspond to the amount of shearing force that occurred, right? That was actually applied to the brain and/or the brain stem. So again, the pathophysiology that causes the clinical manifestations cannot be seen on a scan. It's more on a cellular sort of axonal level. Does that make sense? And these diffuse kind of brain injuries can range from sort of concussion. So a concussion is considered a diffuse brain injury, all the way to sort of more your severe states like that vegetative state that we talked about on Monday. Again, because of irreversible, in terms of the vegetative state, because of irreversible damage done to those axons because of those shearing, tearing, pulling forces on those neurons. So in the case of someone coming in with like a concussive kind of story, you know, a kid on the football field, helmet-to-helmet contact, loses consciousness for a brief moment, comes into the ER with sort of concussive symptoms. If a concussion does not show up on CAT scan, why do we always take these people to get their head scanned? Why? If it's not going to show anything, yeah. Right, to rule out other things like an epidural or a subdural bleed or something like that, skull fracture, things like that. Good. Very good. All right. So there's categories of diffuse brain injury. We've got sort of things ranging as mild as sort of a very mild concussion to more of what we call, there's a sort of term for a classic or classical concussion. And then, so on the very end of that sort of severity spectrum, then you have something called DAI, diffuse axonal injury. These diffuse major axonal injuries are what's causing those things like vegetative state, people not ever becoming conscious again, being unconscious, etc. Kind of those things that we talked about on Monday have to do with the way our manifestations of that overall very widespread axonal injury inside the brain. I'm not going to spend a lot of time on this slide. This is just kind of talking about the symptoms of a mild concussion, kind of some of the stages or sort of levels of severity of a mild concussion, ranging from confusion to some of those retrograde and anterograde amnesias that we talked about on Monday. So this is kind of just sort of a brief overview of what the definition of a mild concussion is. This slide actually shows you more of the definition of sort of that classic concussion. So this would be like the worst sort of version of concussion, so a grade 4 of those other ones that we just talked about on the previous slide. Again, concussions are occurring because you have some sort of disconnect between the cerebral systems from the brainstem and the reticular activating system. So you're going to see a lot of physiological and neurologic dysfunction, again, without substantial anatomic disruption, without obvious changes on a scan. Very common for your classic concussion to have this person lose consciousness for a brief time or maybe even longer, usually ranging under, less than 6 hours. Not uncommon to see some type of amnesia, be it anterograde or retrograde or both, lasting usually less than a day or so after the actual injury. And then not also uncommon to see sort of post-concussive symptoms for quite some time after the initial injury. So these things could be headache, kind of some mood changes, nervousness, anxiety, inability to sort of concentrate, forgetfulness, things like that. And these things can last for months after a concussion, after a classic sort of cerebral concussion. So again, this definition of a classic cerebral concussion is really what you think of when you think of a concussion, when you think of the symptomatology and the complaints of a patient of concussion. And again, the reason I'm talking about this is because this is a really classic, good example of a diffuse injury to the brain tissue. Yeah? No, inflammation really wouldn't show up much either. Now, if you were checking like their pressures, like if you were actually testing their ICP, that may be abnormal, but there really won't be structural changes going on necessarily in the brain. Okay. You guys okay? To make sure, okay. Yeah, question. Chronic traumatic encephalopathy. Yes, it was just on the news this morning when I was getting ready on Morning Joe. Yes. Yeah. No, I believe that. I do. I definitely believe that, and that the long-term effects of multiple chronic concussions can certainly cause neurologic problems. A lot of them being like atrophy of the brain. Because of the sort of inflammation and then back down, inflammation and then back down. It can cause atrophic changes to the tissue, and then also, disruptions in the axonal sort of firing in the tissue itself. There's a lot of discussion about that right now, especially in terms of pro football and things like that. Yeah. But yes, I don't disagree. I definitely think there's something to that. Absolutely. So again, this post-concussive syndrome stuff can really last days to weeks to even months after concussion. So let me ask you this, though. In terms of clinically speaking regarding caring for patients with concussions, why do we educate? Like in the ER, if we take them to the scanner, their head looks normal, but they're having these sort of concussive kind of symptoms, we're probably going to diagnose them with a concussion and send them home. Why do we tell a caregiver or someone who's going home with them to make sure that someone's going home with you, and to make sure that you wake them up every so often throughout the night? I have so many people who there's this myth where they think like, oh, a person with a concussion can't go to sleep because they're never going to wake up. That's not the case. But why do we tell them, make sure you can wake up? Make sure that if you go to sleep that someone's checking on you every so often throughout the night. Why? Why do we tell them that? It's not that they can't go to sleep. It's that we want to make sure that they can wake up. Why? Why do you think that is? Yeah. Ruling out that there's an epidural bleed or something like that. Right. That's why we want them to be monitored. Not because a person with concussion can't go to sleep because they'll never wake up. No, it's basically to rule out and make sure that it's not something else. That it's not a bleed that's going to, they're not going to be able to be arousable, that kind of thing.
If they're not arousable, is that a pretty big emergency?
Yes, absolutely. Yes, because that's probably like a sign of something worse, like an epidural bleed or something like that. Yeah, I know. Just stay up. Just stay up. It's more the fact that if they can't wake up, right? I mean, if they have an epidural bleed, they have an epidural bleed. It's not that going to sleep is going to change that, right? It's the fact that you won't be able to wake them is the problem. Is to wake them up. Well, it's not also that you have to go to sleep, but you know what I mean. It's more of the can they be arousable than are they going to sleep? Does that make sense? Yeah. Because of that axonal injury that has occurred. That's not to say with a concussion that there has not been an injury to the brain. It's not to say that there has not been some axonal injury done to the brain. It's just that if they can still be arousable even though they're drowsy, we're probably not as concerned about something worse like an epidural bleed. But you're right. It's very true. That's one of the big symptoms is fatigue and drowsiness. Right. Okay. Here I also have sort of more of, so I struggle with saying I want you to think of like concussion as more of the mild version of diffuse axonal injury, but it kind of is. Because then if you get sort of beyond more axonal damage, beyond what a concussion really is, then you're talking about more mild moderate, and severe axonal injury. And sort of the grades of that, so now we're talking about maybe like one step up, worse in terms of severity from concussion, would be a mild axonal injury. And again, look at this. One big sort of manifestation of a mild axonal injury is displaying decerebrate or decorticate posturing that we talked about on Monday. So, I gave you that example and showed you that video of that football player on the field who went into sort of decerebrate positioning. He might, I told you they diagnosed him with a concussion, but he might have had more severe than just truly a concussion. He might have been more in this definition of sort of more mild axonal injury. And then more moderate axonal injury, the type of people that would have more severe axonal injury, even beyond mild, would have transitory decerebration or decortication. So this is a patient who may come into the ER because of a head injury, and then even once they go up to the ICU and they're, stabilized and in the ICU for several days, might continue to intermittently posture, right? It's because they have more severe axonal injury than someone with just a concussion or even a mild axonal injury. These are the kinds of patients that might demonstrate sort of unconsciousness for longer than just a few hours. This could be unconsciousness lasting days or even weeks. Again, this is also the kind of patient that may, upon awakening, be confused and have more sort of long-term permanent memory problems and memory damage. And then sort of the worst case of diffuse axonal injury is obviously severe. Imagine that, go figure. This is where the person experiences immediate both autonomic dysfunction and also obviously all of those other dysfunctions that we've already talked about. They may disappear in a few weeks. They probably will have increased intracranial pressure for several days after the injury. And these are the patients who may have profound sensory motor and cognitive system deficits even after the fact. Right? So these are kind of those patients that we talked about both earlier today but also on Monday, saying that they might not be the same person after these more severe axonal injuries in terms of their cognitive abilities, their vocational abilities, their emotional abilities, etc. So you can almost sort of think as these people with severe diffuse axonal injuries as falling into some of those manifestations that we talked about on Monday in terms of issues with arousal, right? So sort of that, vegetative state, sort of more profound complications of axonal injury. Again, may have profound level of consciousness changes, again, usually due to damage done on the cellular level to some of those nerves and axons. All right. All right, so we're going to continue on for a few more minutes. And now switch our sort of conversation from head trauma, so brain trauma, now to spinal cord trauma. Again, we're going to focus mostly, as I mentioned today, on central nervous system disorders. So now we're moving down to spine, still considered central nervous system. Most commonly, spinal cord trauma, spinal cord injuries are due to vertebral injuries. Does that make sense to you? Because it's the vertebrae, that bony sort of protective bones around the spinal cord or around the spinal column itself that either can get fractured or compressed or dislocated or pushed. And it's those bony prominences around the spinal cord that end up getting pushed into the actual spinal cord and causing the spinal cord injury. So spinal cord trauma usually does occur because of some sort of vertebral injury that either results, again, from some sort of acceleration, deceleration, or deformation. So, twisting or bending of the spinal or of those vertebral columns in an unnatural way. Usually, again, because then causing spinal cord injury because it dings into the spinal cord. These forces compress the tissue of the spinal cord, or they can pull on the tissues of the spinal cord, or they can shear some of that tissue. So I think, again, a sort of big layman's myth, so to speak, that is someone with a spinal cord injury is that that spinal cord has been severed and cut. Usually, not at all. Usually not the case at all. Usually, it just got a bad ding from the vertebrae around it. It's still completely intact. It just got pushed. The spinal cord tissue is extremely sensitive. It cannot tolerate any sort of pressure or compression onto that big nerve root. And any kind of compression or pushing on that tissue will cause permanent spinal cord injury. So again, it's way more subtle. It's way more vague than what you think of as, oh, they transected their cord. Usually that does not occur. Usually, literally, the bone just got pressed up against it a little bit. And that's as simple and sort of straightforward as that. So pretty devastating. Most common locations for some sort of spinal cord injury is at C1, 2, or 4 through 7, or thoracic, T1 through lumbar L2. The reason for those two spots as being sort of the most common locations for spinal cord injuries is sort of twofold. One, these locations reflect the most mobile portions of the vertebral column, of those vertebrae. They're just more mobile in that area, so it's easier for them to slide into and ding the spinal cord. But also, it's also where the spinal cord itself fills up and occupies more of that vertebral canal. So it lies in these areas, the spinal cord lies closer to the bone, and then obviously makes it that much easier for any sort of bump into that bone to ding the spinal cord. Here's some really good examples of the types of injuries that may cause spinal cord injury. Here's a really good example of what we would call a hyperextension injury. So this may be someone, diving into too shallow of a swimming pool, and they hit the bottom of their chin on the bottom of the pool and hyperextend their neck backward. So look at this, right? Honestly, what this kind of injury, this hyperextension type of injury would cause is literally just disruption of the intervertebral bodies and of the discs, right? Those little cushions in between each bone. Look how this hyperextension injury just basically folds and makes this vertebral disc just sort of buckle. It's as simple as that little buckling of the disc that causes spinal cord compression, that causes a spinal cord injury and paralysis. I mean, literally that much of a little just sort of buckle in the disc that pushes out and pushes on that spinal cord that causes injury. Here's another good example of another type of injury, a flexion injury. So instead of the neck and chin getting hyperextended, it gets flexed and pushed unnaturally down to the chest. This can cause not only that kind of buckling of these buckling of the vertebral disc as well, but it can also cause fractures. So this is a wedge fracture of the actual bone of one of those vertebrae, and it's those, it doesn't really show you a good picture here, but it's sometimes that buckling of the bone because it's been compressed and sort of fractured that ends up pooching out a little bit and pressing on that spinal cord lying right next to it. So that's a flexion injury. A lot of times with flexion injuries, you'll also see major ligamental damage done in and around the vertebral bodies because of that pulling and that shearing on the ligaments around that area that can also cause issues with instability around the spinal cord. This is also referred to as a comminuted fracture, so it's all sort of splintered up. And again, major risk for some of those bone fragments and bone splinters to sort of smush out and press on the spinal cord. And then a compression injury is when something either falls sort of straight on someone's head or they fall right on their head and it sort of compresses those vertebral bodies. So again, you see compression fractures here that this one necessarily didn't cause cord compression, this one did, right? You see how that bone sort of buckles and pushes out and dings that spinal cord. So here the cord is basically contused directly by sort of retropulsion of the bone or the disc, that vertebral disc, into the spinal cord. Yeah. Yeah, I'm sorry. So this right here is the spinal cord. In all of these pictures, this is the spinal cord. Oh, sorry guys. Sorry. So see how this is buckling right into the spinal cord? Sorry guys. Thought that was obvious. My bad. Here's the spinal cord, guys. See how that's buckling into the spinal cord, guys? Sorry, that's my fault. No wonder you're like, huh?
So are there discs? Are either multiple discs around, or is it one big disc around?
Right. So there's one big disc in between each one of those vertebral bodies all the way around. Like almost, yes, exactly. Yeah. Yep. So either the bone or the disc itself can sort of smush out and press on that cord, which lies right here. Okay. And also same thing, a flexion rotation injury where the body kind of goes one direction and the neck goes the other can also sort of dislocate those bones or dislocate that disc and jump obviously into the spinal cord. Okay. I'm going to do one more slide and then I'll stop. So one thing that I want to be very clear about in terms of spinal cord injuries is that not only can the actual mechanism of injury, the actual damage, cause trauma to the spinal cord. So obviously, clearly, if that bone bumps up into the spinal cord, that's going to cause damage. But there's also a major risk of secondary damage occurring to the cord because of inflammation, because of bleeding and hemorrhaging into the cord. And this is a really good example of that. So this is an injury. So again, here's the vertebral columns, the discs, and then here's the spinal cord running in between that, right? So that's sort of like the real life version of those pictures I just gave you. Is that clear? Okay. So look here. We have a vertebral fracture, right? So here's a bone that's been fractured. You can see the cut. You can see the fracture in the bone right there. And look how it's been sort of retropulsed and sort of dislocated where it actually pushes into the spinal column right here. You see that? Yes? Okay, but look at this. Here's the actual point of injury. But all of this here is bleeding and hemorrhaging and inflammation in the spinal cord. So if this is C7, this hemorrhaging and this inflammation has gone up as high as like C5. So in terms of the way this person would present in terms of their paralysis and their neurologic deficit, their injury would actually look like a C5 injury because of how much damage has been done to the cord, even though the actual injury was down here at C7. Does that make sense in terms of secondary damage? So they can actually have almost like a higher level of dysfunction depending on how much secondary damage and bleeding and hemorrhaging and inflammation to that spinal cord has occurred to actually look like they have even worse injury or higher injury in terms of their spinal cord than they really do. Does that make sense? Okay, so we're going to stop there. We'll finish up on Monday talking about more in terms of spinal cord injury and talk a little bit more about some cerebral vascular disorders before we start talking about kids. Thanks, guys.